Okay, everybody, we're back for part 3, and we're going to talk about hepatitis D. It's uncommon in kids, but must be considered if there's been hepatic failure. It can't cause infection unless the child is already infected with the HPV virus, which is needed to replicate it. Transmission is through parenteral, percutaneous, or mucosal contact, and this can include sexual contact. Incubation is 2 to 8 weeks, and in the U.S. it's mostly seen in drug users. There's no vaccine for it, but the vaccine for the HPV is protective because, as we mentioned earlier, you have to have hepatitis B for the hepatitis D to replicate. Next is hepatitis E. It's found in humans and also non-human hosts. It's transmitted through the fecal-oral transmission route and can be found in contaminated water. It's an acute infection whose symptoms are very similar to other viral hepatitis. Individuals are usually older, adolescents and young adults. Children are usually asymptomatic or only experience mild symptoms, and if symptoms do occur, they are typically within 15 to 60 days after exposure. There are several endemic areas that include India, the Middle East, parts of Africa, Southeast Asia, and Mexico. Most cases in the U.S. are found in immigrants or visitors from the above locations. Clinical symptoms may include jaundice, malaise, anorexia, fever, abdominal pain, and arthralgia. Treatment is supportive. There's no approved vaccine in the U.S., and good hand hygiene is critical. Chronic infection is rare, and recovery is usually complete. Let's next talk about the herpes viruses. We'll talk first about the herpes simplex, and it's widely disseminated in humans. Herpes simplex virus 1 is usually oral labial lesions, and herpes simplex 2 is genital lesions, but both types can be found in other areas. So number 1 can be found in the genital area, and number 2 can be found in the oral labial areas. Both type of herpes can be devastating to newborns based on the symptoms that they can present with. And type 1 is most common in children in gingivostomatitis, and type 2 is usually associated with sexual activity. For neonatal HSV2, that is usually contracted from mother during delivery and is usually seen in the conjunctiva, the nose and the mouth, and any broken skin. It can also occur during a C-section when there's asymptomatic shedding. There can be postnatal transmission. The inoculation from fathers or a lateral transmission from another infant can occur. The period when it's very communicable can be 2 days to 2 weeks. We know with these viruses that the body does not eradicate the virus and that it will lie dormant, and reoccurring infections can occur. And this could either occur as herpes labialis or genital herpes. Clinical findings are going to be based on how the virus was entering into the body, the age, the health of the child, and if they're immunocompetent. For a neonatal infection, you can see multi-organ failure, encephalitis from day 10 to day 12 of life. There may be CNS involvement, and you may note seizures, lethargy, irritability, poor feeding, herpetic lesions, and then there can be issues in the skin, eyes, and mouth, and from day 10 to 12. You can have a traumatic herpetic infection, and that is localized to an area of abrasion where there's been teething or a laceration, and the child can be inoculated by the parent, who may kiss the site. You may see fever, constitutional symptoms, and there may be lymphadenopathy. After the neonatal period, infection with herpes simplex 1 is the leading cause of non-epidemic encephalitis in children. And so you can have a meningoencephalitis. And we talked about the recurrent infection, how the virus can remain dormant and then resurface. Diagnostic studies may include interpartum cultures of mother and child within 12 to 24 hours after delivery. The differential diagnosis could include the Coxsackie virus if viral stomatitis, and you always need to suspect HSV if there's neonatal respiratory distress or sepsis. Management would include parenteral acyclovir for neonatals infections, and you can do oral acyclovir for infants after 6 months of parenteral treatment. Most cases are mild, but you can have a secondary bacterial infection, and it's important to refer any child that has any ocular involvement, whether it's the nose, the eyebrows, near the eye, to be referred to ophthalmology. Patient education is important, so for toddlers and infants with the gingiva stomatitis, they should be kept out of daycare if they are drooling or if they're fever blisters. After that, they may go to school. In wrestlers, they should not compete until the lesions are cleared, as they have close physical contact with their sparring partners, and all women, all pregnant women, should be asked about herpes simplex during labor. The next thing we're going to talk about is mono, and this is caused by the Epstein-Barr virus. Young children often have a subclinical disease, and it's seen more in older children and adolescents. On the clinical findings, you may find lymph node enlargement in the spleen, in the lymph nodes, the tonsils, or in the liver. On a peripheral smear, you may see atypical lymphocytes. There is typically a prodromal period that is mild. You may notice malaise and fatigue in the child. In the acute phase, they can have fever, sore throats, fatigue, rash, and hepatosplenomegalia. A skin rash occurs in a small percentage, anywhere from 3 to 15% of the cases, and may be on the trunk, the arms, and the palms. You will see a gradual resolution in the organ megalia that may take 1 to 2 months to resolve. Diagnostic studies include a CBC, and you may note that there's a greater than 10% atypical lymphocyte count. You may notice elevated liver enzymes, and of course there's the monospot test and the serum heterophile test. Differential diagnoses could include gram-positive alpha-beta hemolytic strep, the CMV virus, rubella, lupus, leukemia, and toxoplasmosis. Management includes supportive care, bed rest, over-the-counter analgesics, fluids, increased calories. Return to play is only allowed after the hepatosplenomegalia has resolved. Usually in healthy children, there's few complications. It's important to educate parents and family about no blood or organ donations after recent infections, and to avoid sharing food and drink. Let's next talk about roseola infantum, which is the human herpes virus 6 and 7. It is typically spread via oral, nasal, or conjunctival route. These subsets of the virus are also associated with encephalitis. It's rare in children less than 3 months and greater than 4 years, and most common ages are between 7 and 24 months. Clinical findings can include a sudden onset of fever for about 3 to 7 days without seeming ill, and they can have a rose-colored macular papular rash. Diagnosis is typically made at presentation, and other differential diagnoses could include any other viral rash, scarlatina, and any drugs hypersensitivity. Management is supportive with using acetaminophen for the fever. It's rare to have complications, but there could be febrile seizures or meningeal encephalitis. Let's talk a little bit about varicella. It's highly contagious. As we know, it's the chickenpox. Shingles, which is herpes zoster, is the reactivation of the latent varicella virus that was acquired from a previous infection. It is spread through direct contact with droplets or airborne transmission. It's important to know that in adults that may have shingles are infectious and can cause primary varicella to children. Incubation period is 10 to 21 days and typically peaks in those that are between 10 and 14 years old. The communicability of the disease is between 1 and 2 days before the rash erupts until the lesions have crusted over, typically 3 to 7 days. Clinical findings include a prodromal phase. It may not always be present, but the child may present with low-grade fever, anorexia, and some mild abdominal pain. You will see the rash with central lesions that are sporadic and crop together. It can progress into macular spots that have teardrop vesicles. As these open and break, they'll crust over. And you can have all different types at once. You may see a high fever, and the lesions can be present on the mucosal tissues as well. There can be an average of about 300 lesions, and the scabs can last anywhere from 5 to 20 days depending on the depth of the lesion. Diagnostic studies include a PCR or a direct fluorescent antibody testing, and then you can do serology for IgG. Your differential diagnosis is for rashes, impetigo. You also need to rule out that these lesions are not cigarette burns or insect bites. Management includes being supportive. It's usually benign. Antihistamines or oatmeal baths are very beneficial for itching. The child can have Tylenol for fevers. Topical antibiotics can be used if there's a bacterial superinfection related to scratching. There may need to be IV acyclovir for immunocompromised patients, and oral acyclovir is not routinely recommended for kids, and it is expensive. There is some thought, though, that to give acyclovir to otherwise healthy children within 24 hours of eruption of the rash, and there can be a decrease in the symptoms and the duration of the illness. If that is something that you may consider, go to the CDC's website and you can find out more information of that. You can have complications with varicella, to include pyodermas, which are skin infections caused by strep or staph. You can have pneumonia, CNS complications, glomerular nephritis, hepatitis, and also a small percentage may present with ITP, idiopathic thrombocytopenia purpura. It's important to offer patient and family education. The child may attend school up to 1 week after exposure unless there's signs of an illness. If they begin to show signs of illness, they need to be kept home for at least a week. If they do not break out in a rash, they can return to school. Children with active disease are to be kept home until the lesions have crusted over. For immunocompromised patients, immunoglobulins can be given, and then they should receive the vaccine within 5 months. All right, let's talk a little bit about the influenza virus. There are 3 types, A, B, and C, and we note that there's epidemics in the winter months when the temperatures are cooler, but you can have year-round exposure closer to the equator. The mortality rate is 0.5 to 1 per 1,000. The incubation period is 1 to 4 days, and the patient is typically infectious 24 hours before symptoms start until 7 days after the onset. I figure with the winter that we've had, many of you have seen a lot of this, so I'm going to go through it fairly quickly. You can have a sudden onset of fever, headaches, chills, vertigo, sore throat, malaise, dry cough. Young children may have nausea and vomiting croup. Infants may appear septic. There may be conjunctival infection, bloody noses, myocarditis. You also may know lower respiratory tract involvement with severe infections. Diagnostic studies have limited sensitivity, but they are available to give a more rapid diagnosis. Viral cultures can be done to confirm diagnosis. Other differential diagnoses include other viral upper respiratory infections, allergic croup, bacterial pulmonary infections. Management is supportive, including bed rest, over-the-counter antipyretics and fluids. Observe for worsening symptoms. Educate parents on what symptoms to call for if things progress. There is a viral resistance to amantadine and ranitidine, so it's encouraged that neither of these be used. Antiviral therapy is important for immunocompromised or those with chronic diseases at risk for complications. And complications can include Reye syndrome, respiratory infections, acute myositis, myocarditis, asthma, and CF exacerbations. Education is very important, and hand hygiene, barrier protection, and social distancing should be promoted with a child that has the virus, and annual flu vaccines. We're next going to look at the HIV virus, and I think I'm going to let you look at that in the book, and we'll skip past that, but the slides are here. So that brought us up to slide 73, and let's talk about measles. So measles is caused by the morbillivirus, and it's very similar to mumps and the flu and can be a serious infection to kids. It's characterized by a rash, and this indicates viremia, which is the presence of viruses in the blood and is considered a serious disease. Most U.S. cases come from unvaccinated individuals that have been exposed to outbreaks in other countries. Worldwide, there's about 20 million people that contract the measles annually, and about 146,000 deaths are noted. And the disease is noted to have spread more within communities where there are larger numbers of unvaccinated or undervaccinated individuals, and where the herd immunity falls below what is needed. The source of infection is carried through respiratory secretions, blood, and urine of infected individuals. 90% of the suspected individuals will develop the disease when exposed. The incubation period is between 8 and 12 days, and you're contagious 1 to 2 days before the onset of symptoms, up to 4 days after the appearance of the rash. Clinical findings include in the incubation period, there's no symptoms. In the prodromal period, about 4 or 5 days, you can have upper respiratory symptoms, a low to moderate fever, cough, coryza, and conjunctivitis. You can also have Koplik spots, which are bluish-white granules that have a reddened background, a red and swollen background. These can be found on the mucosa opposite the lower molars. They typically last only about 12 to 15 hours and are specifically characteristic of measles. During the rash stage, on the 3rd to 4th day, you'll find a macular-papular rash behind the ears and on the forehead. As these enlarge, they can morph together and progress downward. You may see a high fever. Respiratory symptoms worsen on day 3 of the rash, and the rash can become hemorrhagic and lead to DIC. Diagnostic studies could include IgM, this may be useful when the symptoms start. The reactivity is low more than 30 days out. The disease can also be confirmed by viral isolation in the urine, the blood, the throat, or the nasopharyngeal secretions. And measles is a reportable disease and must be reported within 24 hours. Your differential diagnosis includes any viral rash. Management is supportive care. There's no antiviral therapy available. It's important to refer immunocompromised children to infectious disease specialists. And it is thought that vitamin A therapy can prevent complications. You can have bacterial superinfections, and if those present, those are treated with appropriate antibiotics. Okay, so we're going to close out this video and we'll come back and get started on mumps.